upcoming lectures. So, without further ado, providing LGBTQ-friendly care in oncology with Patricia Morfeld, RN, BSN, OCN. And let me just change our camera view here. Patty, welcome. Hi. Really glad to have you here today.
I'm glad to be here. Thanks for having me.
Absolutely. So RN, BSN, OCN, native Texan, we never would have guessed from the accent.
Hey now.
Now Carolinian for 13 years. She's been an oncology nurse since 2010 and is currently pursuing an MSN in Healthcare Leadership and Administration at UNC Chapel Hill. Patty is a previous member of the Patient and Family Advisory Council, or we call it PFAC around here.
Absolutely.
And current member of the Lineberger Equity Council and a member of the LGBTQ community. So welcome. We're really glad to have you here.
Thanks. I appreciate it.
What's one thing we ought to know about your background outside of your professional bio there?
I'm a huge Star Wars fan. And what else? I make great salsa.
Awesome.
And I'm a horned frog. That is where I did my undergraduate work. I lived in Fort Worth for about 20 years, and so I'm a TCU horned frog. But with basketball season coming along, I have to be honest, I am definitely a Tar Heel person. So even though my Tar Heels are playing my Horned Frogs, I feel like my loyalty is going to lean Carolina Blue.
All right, good deal. And let me ask on the Star Wars front. So are you following any of the offshoots now? Andor or Obi-Wan or any of those? Do you have a favorite?
Of course. We absolutely enjoy Andor a lot.
Andor's good. Andor's a little dark. But
it is a little dark. I like it. It's kind of a grown-up one, for sure.
Yeah. All right. Well, poll everywhere. This is just a screenshot. Does heightened acceptance mean increased access or treatment? That's a true, false, A, yes, or B, no, A, true, B, false. And while you're thinking about that, I'll say this activity has been planned and implemented under the sole supervision of the course director, William A. Wood, MD, MPH, in association with the UNC Office of Continuing Professional Development, CPD. The course director and CPD staff have no relevant financial relationships with ineligible companies as defined by the ACCME. The University of North Carolina at Chapel Hill is accredited with distinction as a provider in nursing continuing professional development by the American Nurses Credentialing Center's Commission on Accreditation. A potential conflict of interest occurs when an individual has an opportunity to affect educational content about healthcare products or services of a commercial interest with which she has a financial relationship. The speakers and planners of this learning activity have not disclosed any relevant financial relationships with any commercial interest pertaining to this activity. Phew.
Yeah, I'm not part of Big Game Mafia. We're okay.
All right. So now's your chance to go ahead and complete this poll. So we're at 30% saying yes, and about a third to a fourth saying yes, and about 2/3 to 3/4 saying no.
Mm-hmm.
What do you think?
I think there's a little bit of yes, but it's mostly no.
All right.
So, but I think there is some improvement, obviously, that we've all experienced in the last 25 years.
Gotcha.
So.
All right. Caring for LGBTQ patients with cancer, how and why it is different, and why our communication with patients, caregivers, and each other matters. I'll turn it over to you.
Thank you so much. And again, as Tim said, I am so grateful for all of you taking time out of what I know is a busy week, and your lunch and all kinds of essential things that are happening for you clinically. So thank you for being here and taking this time to spend with us. The first thing I really want everybody to do, and I wish we could afford it, but I do not have Beyonce kind of money, but I loved her album this summer, and in particular, the song Cozy, which was quite a jam, and if you haven't heard it, I encourage you to look that up on YouTube, but really focusing about being comfortable exactly where you are. And so I really want to encourage everyone who's taking part in this conversation today to be just exactly where you are. Some of us have had the opportunity to do a lot of learning on this topic, either as healthcare providers or with friends and family or ourselves. Some of us have gotten enough information to be able to feel slightly capable, and some of us just feel incredibly awkward and unsure. And all of that's okay. The reality is this is just an open conversation, and this can be the start of a conversation for you. The other piece that makes this complicated is so much of the time, our culture in the United States is not great about talking about sexuality or sex, and those are not the same things. Today, we're talking about sexuality and allowing people to be their authentic selves. We are not talking about sex. And if at some point we are talking about sex, this conversation has taken a very wrong turn. So, we're just trying to talk about who people are and what best represents them and how we can meet people, treat them as patients and caregivers and colleagues, and be able to make space for people to be who they are, because that really does mean we're caring for them as a whole person. And that leads to better care and more transparency for providers and caregivers. And that leads to better results for everyone. We all would want that kind of healthcare. And certainly that can reduce a lot of frustration and stressors for nurses and physicians and everybody who's at the bedside or providing care remotely. All right, our goals for today are going to be threefold. We're going to focus some on vocabulary, but in a broad sense. We're not going to be going down the rabbit hole of every possible title or community name or definition, because those names and definitions change frequently, and people change. And the reality is we don't need to get so focused on that kind of minutia that we miss out on the big picture. The goal here is to create open communication and dialogue, and for you to feel prepared for any kind of conversation you might need to have, not to worry about the very specific words and language. We're also going to be talking about how we can have conversations and how we can initiate conversations, or sometimes how we can redirect conversations to help both ourselves learn, as well as patients and caregivers, and sometimes colleagues also, if there's a situation that presents itself. One of the big issues with names and community names and identifying people by specific gender or specific title is that one size does not fit all. And we are looking to do the best job we can to take care of our population of patients, all of our patients. And so being able to recognize that there is some nuance there is an important part of this conversation. Then we're also going to make sure that you have resources. I'm going to share some resources here that are available locally at UNC Health in Chapel Hill, but also as part of the UNC system, and then also within our electronic medical record, and then also some national resources that are available online. I've got some links at the end. Additionally, if there are questions or concerns or things you'd like to keep talking about, or if you need an ally for a conversation, I am available and I would love to talk to you. So you are welcome to reach out to me. So beginning this conversation, I don't know, obviously, the age range of people that are on here. I am newly 54 myself, and so I grew up and was becoming a young adult in the late 1980s. And so for someone who's on this call that is 30 or younger, some of these conversations and some of this information can seem like kind of silly, like, well, obviously, or of course, well, sure, why wouldn't we do that? Unfortunately, for folks like me who grew up and were part of receiving healthcare or part of the shift that we've had in public thinking about the LGBT community and the LGBT community in healthcare, that's a big change. Our country, and as well as internationally, has made lots of progress on this particular issue. And some of that progress has been in real meaningful change, and some of that has been in collective attitudes and a reassessment for people about what a family can look like and what caregivers can look like, and broadening those definitions. But the reality is 1986, 1987, 1988, that's not ancient history. And so for a lot of our patients that we take care of in oncology who are 50, 60, 70 years old, a lot of those folks were living through the AIDS crisis, and it was a very different time. LGBTQ rights, there was slow growth in that area. It became busier, and there were more things happening in the 60s and 1970s after the Stonewall riots, and there was more quiet advocacy and consistent advocacy and pressure by a variety of groups. But what really changed was the advent of HIV and AIDS, and the basic abdication of responsibility by a lot of healthcare providers and governments across the world who decided that HIV was a gay man's disease and therefore not a priority. And unfortunately, that played out across the country and across the world, with many people suffering and not receiving the kind of compassionate, patient-centered health care that they deserved. For a lot of people who lived through that time period and did manage to live through that time period, there's a lot of memories of not being able to visit people they loved at the end of their lives, or not being able to bring people home, or having biological family members or parents who didn't want their child to be identified as gay, or didn't want the neighbors to know they had a child who died of AIDS, preventing them getting to be at the bedside with their friends. That's a lot. And so if somebody shows up after years of not having great experiences in a healthcare setting and now has their own diagnosis, or is a caregiver for someone with a diagnosis, they may be rightly suspicious or concerned that they can't be as open about who they are, or that they can't be as open with any of us about where they live, who their closest people are. All of those kind of things factor in, and making sure that they have the ability to make decisions if they're incapacitated or if their partner can, things like that. A lot of things helped shift public acceptance. Some of that was the advocacy by groups like ACT UP, Gay Men's Health Crisis, and the Human Rights Campaign, and lots of other organizations, as well as lots of people from outside the LGBTQ community coming forward and being visible and vocal allies, and making sure that everyday people understood that they probably love somebody who is part of the LGBTQ community. Both public and private people also coming out and sharing with their colleagues or family or friends their own identification, or the fact that that they had been worried about identifying themselves. That also played a role, because more people became exposed to lesbians at work, or a transgender person who ran the bookstore. Additionally, one of the big factors has also been that the LGBT community has used its political force and money to also advocate for itself, and also force representation on a bigger platform. So that representation in the media, in movies and music, books, TV, all of those things, that LGBTQ characters weren't always cast as the victim or a predator, which unfortunately for many years was the case, and that stories and even news program analysis were always focused on the mental health struggles of being gay, or predator ideas, or conflating homosexuality with predator type behavior, all things that had been clinically and many times rebuked and rebutted, but were still allowed to be mashed together in the view that people had of the LGBTQ community. So making those changes has made a real positive impact for people and made it easier for people to be able to be authentically who they are. And it's also made it possible for people to have the opportunities professionally to be who they are, and getting protections worked into unions, protections written into law to prevent discrimination in housing and employment. When I was figuring out who I was in the late 1980s in Texas, I had lots of friends who were never going to be able to go through the school of education and be out of the closet, because you couldn't be a teacher and be gay, because people would automatically assume you were doing something nefarious. There were also lots of people who wanted to serve in the military or wanted to look at being part of law enforcement and were worried that they could never authentically be who they were if they chose those professions. Gratefully, lots of that has changed. It hasn't changed everywhere, and there are still plenty of pockets of intolerance and places where people don't feel like they can be who they are all the time. So having this heightened acceptance and exposure does not necessarily increase access to treatment. Research done, this research in particular was for the Oncology Nursing Society, showed that after review of data from all of the research done specifically on LGBTQ people related to healthcare, that most of it, the majority of it, was focused on HIV and AIDS, as well as family systems and general health. But oncology related research was very limited, almost non-existent. That is something that is slowly changing, but part of how that's slowly changing is by accuracy of data collection and by including SOGI data, which I'm going to share with you in a little bit. And why that's important is making sure that people are identified correctly and that institutions are collecting that data, so that when researchers go to pull information from tumor registry boards and things like that, they're getting a full picture of the community of people that are being treated. And so that we can more clearly identify risk factors as well as treatment outcomes, survivorship, all of those kind of things.
All right, so here's that next poll question. And so all of the following are barriers to accessing and receiving care, except, and A would be lack of insurance coverage due to a lack of insurance from domestic partner. B, fear of discrimination. C, lack of coverage for screening exams if they identify as different gender on their insurance card. Or D, all of the above. And please take another 20, 25 seconds or so to think about all of the different answers and then select the one that you feel is correct. And again, totally anonymous, so. Right, Patty, how are they doing?
Great, yeah. This is a category where it's really all of the above. When we're talking about barriers to care, this is one where this is identified routinely. Many organizations have done research on this as far as a lack of insurance coverage. LGBTQ people are more likely to have employment issues or employment related that doesn't have good employer related insurance plans. Even with those plans, if there are not provisions for same-gender partners, domestic partnerships, or even married spouses. Sometimes there are insurance workarounds, especially for smaller companies. They are not required to offer those insurance benefits. And additionally, if you're on a plan that does not offer a lot of coverage for screening exams like mammography, colonoscopy, things like that, especially if you identify as a different gender, there are transgender patients who still need to have a mammogram, even if their identification lists them as male, or if they need to have a pap smear, if their identification acknowledges or notifies that they're a male. Those things are still important. One of the hard pieces then for people is that in addition to worrying about whether or not you're going to be accepted when you go to the doctor and you need to have a mammogram, but you present as a male person when you walk into a clinic and you look like a man, you're already kind of spoiling for concern or worried that you're not going to be accepted. But then if you're concerned that your insurance is going to reject the claim and you're going to have to go through multiple calls with different people at an insurance company who are not well educated about all of these issues and re-explain your entire life history to them and the most personal and intimate details about yourself. It should be fairly common sense to anyone that if you have a cervix, you need to have a cervical exam. And if you have breasts and were born female, that you might need to have a mammogram. Unfortunately, that's not common sense. And I think most of us probably already know that because we've worked with insurance companies at some point in our professional life. So that's a real barrier. People can also really resist coming if they've heard from other people in their community or family members or just the historical information of, oh, they weren't very nice, or they treated me funny, or I felt like everybody thought I was weird, or, I didn't get a good vibe from them, or they looked at me funny when I asked them to call me Pat instead of Patricia. Survivors are less likely to participate in survivorship programs. They're also more likely to be lost to follow-up, which is critically important for us as far as being able to make sure that people are getting their 6-month, 1 year, 2 year, 3 year appointments to make sure that they haven't had any return of disease or illness. They're also less likely or more likely to wait for palliative care or wait to make end-of-life decisions because they're concerned that they may not have those decisions honored or that they may not be able to have the people that they want at the bedside. Some of that can also be attributed back to the insurance issue. If they are still on a parent's insurance and their parent, and this can be for young adults. I have a 22-year-old and a 24-year-old. If my kids are on my insurance and they're being admitted to the hospital for something, sometimes people that age are resistant to necessarily identify who they are or who they want there if they are not completely open with their parents or if they've had problems being open with their parents.
All right, and here is that next poll. So what organization sets the standard for the hospital to allow a family member, friend, or other individual to be present with the patient for emotional support during the course of stay? And would that be A, the Joint Commission, B, Center for Medicare and Medicaid Service, C, American Hospital Association, or D, United States Department of Health and Human Services? And thank you all so much. People are just jumping right in there.
I know, that's great.
Answering the question, and we've got a variety of different answers, which is terrific. So let's take about another 10 seconds, and then we'll
got my trigger finger here with the forward button there.
Awesome. All right. So, Patty, how are they doing?
They're doing really good. Yeah. So in 2011, the Joint Commission actually recognized and set a standard for this to make sure that people could have who is most important to them with them when they are hospitalized, and that includes in the emergency room. The standard is that any family member, friend, or an individual can be present with people to provide emotional support during the course of their stay. Inpatient stay, outpatient stay, emergency room visits. The only clarification on that, of course, is that if it infringes on their safety for some reason, and we can all think of circumstances like that, but this is somebody that gets to be chosen by the patient. And so that means even if they're 20 and mom's paying the insurance, they can still say, this is who I want with me. They do not have to be the person who's making their legal decisions. They don't have to be their power of attorney. It can simply just be somebody that is important to this person's life. Moving into our language a little more. So it does not have to be perfect. And that is what I really want to stress. We are going to mess up, and that's okay. Our language doesn't have to be perfect. We just have to be honest and honest about trying. Why do we always have to talk about someone's sex life? No, we're not talking about people's sex lives. We're talking about their gender identity and their sexual orientation. Those are not equal to sexual behavior. Not now, not ever. Why do I have to call her by a man's name? Nope. Calling somebody by their chosen name does not impact your ability to perform your work or to provide the kind of care that people deserve to have. Well, why do I have to make an accommodation if I don't agree with their lifestyle? Part of accepting responsibility for being part of a healthcare organization and being a healthcare worker is recognizing that we care for everybody, not just the people we like or want to spend time with or the ones that we agree with. If that was the case, my waiting room would look a lot different. I would be able to turn all of the television sets off in our entire department off of Fox News during all election times because it's a lot. But again, we don't do that. We care for everybody. We care for people from the Department of Corrections. We take care of everybody. And so that means we respect people where they are and provide them with respectful care that addresses their needs. Well, why does this matter? I'm just trying to take care of their lung cancer. I'm just trying to take care of their breast cancer. Why do I care? Well, we're trying to treat a whole person. And oftentimes that also means taking care of the people closest to them and making sure that they have the resources that they need, making sure we can fully assess what's happening for them, where they live, who's with them, who's providing financial support, how they're getting here. We want to make sure that the care we're providing addresses those things and we can create a treatment plan that really works for them. And in some situations that may mean their partner is going to come with them for the whole time. And that's true for all patients, not just LGBTQ patients. I'm so afraid I'm going to screw up and say the wrong thing. Okay, well, let's just, again, you're going to. At some point, you're going to say the wrong thing. And most of the time, people recognize when you are trying, when you are doing your level best, and you just misspeak. One of my sons has a dear friend who is transgender, and during the first couple years of their transition, I routinely screwed up and used the wrong pronoun in front of them, and I would correct myself, and we would move along. And Ainsley absolutely understood that I was doing my best and I was learning and was appreciative of that and understood that I was not trying to be discriminatory or hurtful in any way. So the best way to do this is to make this a habit. And that means ask people, what do you want me to call you while you're here? You know, do you want me to call you Mrs. Jones? Do you want me to call you Ann? Do you want me to call you Grandma? Want me to call you Bill? Where do we go from here? Who are the most important people in your life? Who's going to be coming with you for your appointments? Okay, great. And so your mom and your sister or your friend. And people oftentimes, if they're comfortable and they know that they're being welcomed into a comforting environment, they're going to self-disclose if they want to. And you've opened the door and made that possible for folks. Giving people their time and the autonomy to be able to tell you how they want to be addressed and who's important to them is critically important. And if you screw up, you say, I'm so sorry, let me start over. This seems like a small thing. It's not a small thing to identify people by the right name. And for a very simple example, I can tell you my given legal name is Patricia. If somebody calls me Patricia, I assume I'm in trouble, like getting sent to the principal's office. Alternatively, if somebody calls me Pat, I assume that they hate me or that they are identifying me with some terrible aunt who made them scratchy sweaters when they were growing up. I don't know. It just absolutely gets all over me. So imagine if I go in for my appointment and the doctor continues to call me Pat, even though I have corrected them multiple times. And now I'm supposed to say, yes, please give me my annual pap smear. No, it's rude. It's disrespectful. I asked you to call me Patty. That's not a big ask. Just like it's not a big ask for any of our patients, no matter what they look like, where they're from, how they started at 5 years old to where they are at 50 years old. I certainly do not look like or act like or think like the person I was 25 years ago in many ways. And so I get to change and grow, and so do our patients. There are too many names. I know I'm going to screw it up. Again, yes, we're all going to make errors, and that's okay. What we don't want to do, though, is get so focused on the minutia of this person's bi, this person's this person's polyamorous, this person's this person's this. That's not your job. Our job is not to be handing out the labels at the label maker machine. We're not doing that. We're going to focus on the big picture here. And the big picture is that we want to make sure people are able to identify themselves and their caregivers and what's important to them. And that we're going to treat them like unique human beings, and we're going to center our care and make our care as patient-centered as possible. And so that may mean different resources depending on patients, and reaching out for different resources, or reaching out to say, you know what, we have a new patient who's trans and I think may need some more support, or may need different support, or they're on some extra medications that I'm not familiar with, and I need to find out if any of those are going to impact their care for their cancer diagnosis. It may mean that you have to do a little more research and digging, but that's, again, why we're all here. Some patients are going to come and they're going to just absolutely right off the bat say, this is my wife, and she's going to be with me for all of my appointments. Some people are going to come and introduce their longtime roommate, and they're never going to say that that is their husband or spouse, and both of those things are okay. Depending on their career, depending on their age, depending on their religious background, spiritual background, family system, everybody's journey is different. Both things are okay, and anything in the middle. Some of our patients are going to arrive and they're going to be dressed as the gender that they present as. Some are going to be presenting in an opposite gender. If you work in cancer for very long, you know you're going to meet a lot of bald people of every gender, and lots of people are going to come for appointments in their pajama bottoms, male or female, or transgender, and that's okay. It's completely irrelevant what clothes people are wearing. I love to wear girly clothes. I also love to wear a baseball cap and jeans. Neither one makes me more or less female. That's just clothes. For patients who are going through a cancer journey, we see many patients, no matter where their gender or sexuality is, who go through a cancer diagnosis and may come out the other side of it and decide that they want a different career, they want a divorce, they want to make some major changes in their life because they've been faced with having to make some really serious decisions and their mortality. That's very normal. We do have patients sometimes who will arrive for their initial treatment, and then 5 years later, they arrive for their initial treatment and they're married to someone of the opposite gender and have had that specific life. And 5 years later, they may come and say, okay, this is my new partner, and they're the same gender. And that's also very normal. There are lots of people who have stayed closeted through their 20s, 30s, and 40s because of professional worries or family worries, and then got to a point where they decided they were done with that part and wanted to come out. And so this can happen all along the age range for people. How does all of this apply then for working with each other? So part of working at UNC Health and other large organizations, we do have built into our hiring processes non-discrimination work, and we all in part of UNC Health is in fact does include annual education for LGBTQ patient care, and that's partly encouraged by the Human Rights Campaign and their annual survey of healthcare organizations. Why it's important for all of us to have these kind of conversations is that being visible and making it very apparent to your colleagues that you are a welcoming individual and that you prioritize people being able to authentically be who they are actually makes it possible for people to do better work. People who don't feel like they have to hide part of who they are, or people who feel like who they are is going to be respected, are obviously going to do better work. That's pretty much common sense. Visibility wise, it helps because it also means that if a staff person is unsure and they're working with someone else or they have a new patient and they are concerned about them getting resources, they are going to feel like they might be able to reach out to someone if they know, oh, hey, I know Patty has more details on that, or I can go and find out, or I know somebody I can ask questions to. For all people, leaders, and I include pretty much everyone who's on here, because if you're working in healthcare, no matter what part of a hospital or healthcare institution or organization you're part of, you're working in a role that impacts other people. And so part of what you're doing is providing leadership, even if it's in small, quiet ways based on asking people these questions, or if it's making sure that you're creating a safe environment for people to work in. We have to be 100% clear that all kinds of staff and the expectations for behavior is 100% clear to everyone. And that staff who are LGBTQ are supported by leadership and included in conversations when we're planning for holidays and vacations and inviting people to team events, that everybody gets to bring partners or nobody brings partners, or we're having a baby shower and we're also going to have a baby shower for this same gender couple, the new pharmacists are having a baby. All of those things have to be included. Also, honoring people's privacy. Some people aren't ready, and that's okay too. Some people don't want to talk about the private life at work and they want to keep a wall there and they don't want to share any of that. And that's 100% okay as well. When people come forward and share issues or concerns or tell staff or leaders about inflammatory language or abusive language or discomfort, that needs to be addressed clearly and as soon as possible. And we have to realize that the attitudes are cultivated throughout an organization by leaders. And so leaders who are welcoming and leaders who are intentional about making sure that education opportunities are available for people, that all kinds of patients, all kinds of staff are celebrated. That visibility is crucially important. Sorry, I'm just checking our time. So for patient care and for staff work, we're going to assume good intentions. And this is where we're going to fall back into yes, we're going to mess up because we're humans. We're going to say the wrong thing. One example I would share that I think most nursing staff have had the displeasure of making the error is the 25-year-old wife with the 80-year-old patient. At some point or another, most every nurse I know has misidentified a 25-year-old wife with an 80-year-old man as a daughter, and then had to try and reel that back without absolutely humiliating everyone involved. I've done it, and I've done it to the point where it took me a good 30 minutes to figure out I was misidentifying the wife as the daughter, despite the fact that they were giving me every visual and verbal hint they could. It just did not sink in. And so, of course, I was mortified after I left the room. Nevertheless, they accepted it with grace. This is a similar situation here. You have a coworker and they're complaining. Well, why I don't want to talk. Why do I have to say they, them? That's silly. Okay. Well, why do you think that's silly? We're going to ask why questions, because sometimes it's silly because it's just something they haven't done before. So you're going to say, well, why do you think that's silly? Well, it's just not something I'm familiar with, or I haven't seen it before, or I don't understand why that's such a big deal. Well, you don't actually have to understand. But this patient, it was really important. That's really amazing that the patient felt like they could share that with you and that they could be honest about who they are and what is important to them. And I can imagine that they've probably struggled with that for a long time. And so being able to tell you that was a pretty big step. And sometimes that's all you have to say for us to other people to start to reframe these conversations in their heads and to understand that that learning happens little by little. Patients, caregivers sometimes can say inflammatory things. We had a situation a couple years ago where a patient we had taken care of for several years, who was affectionate and liked us and brought us cookies and all kinds of things, and made the comment very loud, was very rude, being very rude to a staff person that they assumed were gay. And the staff person was upset and came to me, and I was charge nurse that day, and I said, I got this. So I went around the corner and I was like, hey, blah, 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 blah. I'm going to take your IV out, get you ready to go. Oh, well, I just don't like being taken care of by so-and-so. I just don't like gay nurses. I just don't want to be around gay people. And I said, wow. I said, that's really unfortunate. I said, that's dangerously close to saying, you don't want a nurse that's a different color or something. Oh, no, I would never say that. And of course, the patient was like, oh, no, I would never say anything like that. And so I finished taking his IV out, and then I leaned really close and made eye contact. And I said, and just so you know, for the last several years that you've been coming here, you have been taken care of by a gay nurse. And slowly pointed to myself. And needless to say, his eyeballs became like saucers. And at that point, he just kind of swallowed and said, oh, well, all right then. And I said, okay, well, we'll see you next time. Take care. And the next time I treated him the exact same, and things moved along. Did it change his mind? Who knows? But did it change his behavior while he was in our clinic? Absolutely. And it also reinforced to my colleague that how they were feeling and how they were being treated was important. And having me say that out loud in our clinic setting made an impact, because it validated my employee, but it also reinforced to our patient that we're not going to accept that kind of behavior, that we take care of all kinds of people from all walks of life. And that's important. And if they don't like that, then we can absolutely help them find other care. And when presented with that option, most of the time people are like, oh, no, I'm fine, because it's unreasonable. We're not going to get to pick and choose every single person who takes care of us, who they vote for, what they look like, where they live, what their financial status is, what religious background they have. All of that is truly irrelevant when it comes to providing care for our patients. SOGI data is our sexual orientation and gender identification data. And this is something where there is an actual field within Epic in our electronic medical record. This is information that organizations are required to have as part of their electronic medical record. They are not, however, required to have it collected on every single patient, which, as you can imagine, is not very helpful. Getting this information collected can really help improve patients' experiences, as well as improve our data collection for research, clinical trials, and being able to report out research for patients in different populations, whether that's LGBTQ folks, whether we're talking about transgender patients and their cancer follow-up, screening exams, all of these kind of things. Because we're a research institution and we're part of creating new care and new types of care for people, this is a no-brainer. We should be collecting this information for everyone. I have a link here that will take you to a site on our intranet if you are an employee at UNC Health. That is an Epic tip sheet that can show you how to do that. And there is also a component within our LMS that will let you get more information about how to ask some of those questions or how to steer patients towards asking them, because it can be a little awkward. But having that training and practicing some of those questions with coworkers can make it much simpler. The other thing is that if you're asking this information for people, sometimes patients will be like, I don't need to answer any of that. I've been married to her for 50 years. Why am I answering this? And you can just say, we're doing this for everybody so that nobody has to feel like the odd person out. We want to have this information for every single person. And it's important for research for every single person, because it is. And unfortunately, for so long, research has been dominated by male patients and often white male patients. And we want to change that narrative going forward.
All right, and here we've got that next question, and let me, there we go. So current EMRs are required by the Center for Medicare and Medicaid Service to have the capacity to collect sexual orientation and gender identification information. A, true, B, false.
I
And
kind of gave the answer already,
I
didn't I?
think you might have given it away a little bit,
Sorry.
but I also think they were listening.
I'm the
So,
gal. I've got a mouth. What can I say? I got a
well,
mouth on me.
you're communicating you're communicating effectively. So how are they doing here?
They're doing great. And so it is a requirement for electronic medical records to be able to capture that data. It is not a requirement to collect it. And so that's the real discrepancy here. They are required to have that. As I said, there was a link on the tip sheet on the page before. However, it's not based on, there's no requirement to actually collect the information. And unfortunately, because the Department of Health and Human Services is part of the federal government, some of those policies change based on who the leadership is in Washington. And so federal officials, as we've all seen over the last several years during the COVID pandemic, change policies based on political decisions versus healthcare decisions and versus what's in the best interest of patients and long-term patient care. So this is one where voting and being aware of what policies are being put forth by organizations is important. If you are part of organizations like Oncology Nursing Society or ASCO or other professional organizations, you should be making sure that they're advocating for the collection of SOGI data and tumor board registry data, because that's how we get the information we need to be effective and do the work we need. Again, I want to reinforce Brene Brown is one of my favorite writers, social worker people, and talking about truth and transparency and vulnerability and being open with people. And trust is not built in big sweeping moments. It's built in tiny moments every single day. And this is an issue where this is truly important. It's very easy for all of us to get caught up in the big stories and things on Twitter and social media and forget that we all work in smaller communities and smaller places. We're not taking care of the entire world. We're taking care of our part of it. And if we can make our part of it more welcoming and be able to allow people to be their authentic selves while they're with us and trusting us to care for them fully, and their caregivers are able to build that trust as well as that trust with our colleagues, that's truly not a small thing. That's a tiny miracle right there. I thank every single one of you. You're welcome to ask questions. I want to make sure I thank all the people in my life who've allowed me to be who I am, and especially my kiddos, Nick and Henry. I've got lots of references for you, and then I also have some great links for information. The Human Rights Campaign and their Healthcare Equality Index, there's information in there. Dana-Farber has great information for LGBTQ families and patients that's specifically oncology related. UCLA Health has a great program for LGBTQ patients of all kinds, not specifically oncology related. Then the National LGBTQIA Health Education Center, which is comes out of Boston, has wonderful information and lots of resources. Trevor Project is a great resource for all kinds of patients as well as caregivers. The National Coalition for LGBTQ Health has a great partnership with the Society for Gynecologic Oncology, where they provide a whole education program. It's 7 separate online classes that are completely free on providing welcoming care for LGBTQ patients. Includes great classes, and you can get extra CME credit for those too. So I encourage you to follow some of those links. And again, encourage you to reach out to me personally if there's anything I can do, or if you need help with a project or have a question or need an ally, I am always available.
Patty, thank you so much. This
Thank
has
you.
been a wealth of information, and we are really appreciative. Now's the time when our audience can go ahead and share their questions.
Absolutely.
So go ahead, type those into Poll Everywhere. We'll look at those. And while we're waiting, so if a patient, an LGBTQ patient, feels they're being discriminated against or is concerned about this, what sorts of actions can that person take? Either in terms of vetting or in terms of once they're under care and start to feel like, well, maybe I'm not being treated fairly.
Well, nationally, some of the organizations I mentioned actually have lists of providers who have done some of the hard work as far as done some education with their staff, have realistically laid out the fact that we know caring for LGBTQ people is different, and we want to make those accommodations as an organization as well as on an individual level. And so that's one resource people can look towards that. Yeah. If a patient is already in care and is received and has concerns, especially with our organization in particular, they are welcome to speak to someone in leadership for the clinic that they're part of. Also with patient relations, we also have an incredible team with our comprehensive care and support program as far as social work and our chaplain, all of whom are welcoming and supportive staff and people that will absolutely advocate for patients and families and make sure that they're receiving the support and care they need and bring those concerns to clinic leadership.
Great, thank you. And I guess I'll extend that question to, if as a healthcare professional you feel that one of your colleagues is being discriminatory, what would be the recourse there?
Absolutely. And in cases where my hope would be that you would have a relationship with your own manager or leader, that you would be able to go to them to report the issue and that they would be able to take action at that point. Recognizing that we still have times where we don't feel comfortable or we don't want to necessarily have our manager know about our private life. We do have employee relations and human resources. We do have specific guidelines for behavior and expectations, and that's taken seriously. And it's not something to shrug off, because that kind of negative behavior grows when it's ignored or put off, oh, we'll do it tomorrow, or we'll talk about it next time, or whatever. Yeah. We're not going to do that. And that is truly why I say, if you need an ally and you're part of this conversation, or you know somebody who does, you are welcome to reach out to me and I will help you brainstorm or figure out the right people to talk to. We do have a healthcare, or UNC Health has a organization-wide program for diversity and equity and inclusion, and that does include an LGBTQ program and a program for transgender staff, and provides access to other resources and can make sure that help you advocate or learn to advocate for yourself.
Great.
Or another staff person.
Thank you so much. And I was just checking my phone to make sure that the poll was open and working. Sure. So it is. Let me check and see if we've gotten any other questions in here. I'm not seeing any, and nope. I know we are coming up to the hour. Sure. Let me go ahead and navigate through a couple of other things, and then if you just thought of a question, or you're taking time to get that typed into Poll Everywhere, or if you're struggling with some element of Poll Everywhere, you can even just drop that in the chat and we'll take it there. But either way, while we're doing that, let me go ahead and jump ahead a few and just say thank you. Thank you first and foremost to Patty Morfeld. Thank you so much to the people of North Carolina for their generous support of the University Cancer Research Fund and the UNC Lineberger Comprehensive Cancer Center that they make possible with their tax dollars. So thank you. Thank you to our team at the Cancer Network, the Lineberger Cancer Network, Veneranda Obore, John Powell, Oliver Marth, Andrew Dodson, Nadja Brown, Patrick Muscarella. All of these folks work really hard to make all the behind-the-scenes work to make these happen. And let me go back and just check and see if there have been any. Yes, looks like we've gotten a couple. Okay, here's this first one. Should pop up in just a second. Are there evidence-based practices we can employ to encourage LGBTQ survivors to attend follow-up appointments?
That is an excellent question, and that would be an excellent research project for someone. There are not a lot of established data on all of this, and that's part of the real difficulty is that we don't have good information. Research has been very limited, and so in addition to making sure that appointments are and getting those follow-up appointments scheduled and making sure that they're accessible in a different ways of media has been one thing. Making it possible for people to do telehealth visits. I know that's been very helpful for people during the pandemic, and I'm grateful that more insurers are starting to cover more of those things. That really does help, especially for people who are coming from a distance, the expense issues or having to leave work, some of those things. So I would really say right now it's an area where we need more research, but that the primary way to improve that is having more accessibility. And so having telehealth appointments available has made a real difference for people.
Great. And then thank you so much for that question. There are still many more systemic policies at UNC that exclude trans people, like no gender neutral bathrooms or forms that say he/she instead of they. What is being done at a more systemic level to change this? Thank you for that question.
So for the university itself, I cannot speak to that piece of it. I will tell you that for many years, there were Joint Commission rules and CMS rules regarding bathrooms and having to have a certain number of bathrooms with each gender on every different floor, which of course we all know is complete and total nonsense. We are moving towards being able to change more bathrooms in clinic areas so that they are just a bathroom. And what we frequently tell patients in our clinic is we do not care what bathroom you use as long as you wash your hands and flush. Now, overall, as an institution, that is one of the topics that the DEI committee, I believe, is working on for the whole organization, as far as removing some of that same gender-specific nonsense from bathrooms. As far as forms as far as the electronic medical record forms or things that are within the electronic medical record do offer a they/them option. As far as printed materials, the updated printed materials that come out of our electronic medical record will also allow for that. I am not sure about any of the consent documents, but most of the consent documents print from an individual's patient medical record, and so should have that information just as the patient reports it in their SOGI data. As far as old paperwork and forms that are not generated directly from our medical record, there is always the problem of the fact that they are outdated and need to be gotten rid of. I know there's a forms committee for the institution that updates and gets rid of forms or updates them. I know one of the biggest and most impactful things I learned from a nurse educator this year actually was that, we need to stop with the homegrown education stuff and the homegrown education materials, because so much of the time we print out lots of these things and then they're outdated a year from now. And so, and thinking about that, it was just like a light bulb went off in my head, because I was like, well, yeah, that's pretty obvious. Of course it's outdated. We're using different equipment or different this or different that or a different medication. And so you've gone through all of this trouble and then you're handing this document to someone and then they get home and they think this doesn't look anything like what I just went through. Okay. So using things that are done and are part of our electronic medical record and some of the education materials that you can use with the dot phrase to put into discharge papers, those are updated more frequently. There's also the committee for updating policies for the institution. And if that's something you're interested in, you are welcome to email me and I will get you information about that. I'm sorry I can't provide that off the tip of my tongue.
Patty, thank you so much.
Thank you all so much.
Those were great questions.